The knee joint undergoes large mechanical loads during daily activities, especially during incline walking. One of those loads is the tibiofemoral contact force, which depends on the net joint reaction force and the muscle forces for muscles crossing the joint. High forces are potentially damaging to the knee joint, especially for patient populations that can have abnormally high joint loads. Powered exoskeleton assistance has the potential to reduce the tibiofemoral force by reducing the effort of the muscles. In order to quantify this, we need to use musculoskeletal modeling, which has three primary methods. First, static optimization, CMC, or EMG-Informed. The EMG-Informed methodology provides a more representative estimate by considering co-contraction and the user's actual muscle activation compared to the other methodologies. Therefore, for this study, we aim to investigate the capability of assistance using a robotic bilateral knee exoskeleton, shown in Figure 1, to reduce the knee joint load in able-bodied adults walking uphill using an EMG-Informed model. We hypothesized that assistance provided at the knee joint during early stance will reduce the quadricep force, which is the primary contributor to the knee joint load during uphill walking, and thus decrease the peak knee joint load during early stance phase compared to the unpowered condition. To do so, we had 9 able-bodied adults walking on a treadmill at a 15% gradient at 1.1 meter per second. We compared two conditions, a biological torque controller and an unpowered condition. The experimental setup is shown in Figure 2 for your reference. Figure 3 displays the assistance profile for the biological torque controller, in which extension of torque was provided for the first 30% of the gait cycle. Using the data that we collected, we estimated the joint load using an EMG-informed neuromusculoskeletal modeling. OpenSim was utilized to calculate the knee moment, then the exoskeleton torque was subtracted to obtain strictly the biological knee moment. Additionally, a linear envelope of the activation was obtained and then normalized to the maximum voluntary contractions. These were utilized as an input into the calibrated EMG-informed neuromusculoskeletal modeling toolbox, or CNMS, where an objective function was optimized in order to adjust the experimentally collected activations to better match the torque, as well as synthesize activations for muscles not experimentally collected. Using this data, we were able to then calculate the muscle forces with the hill-type muscle model, and then using those muscle forces as well as the joint angle and external forces collected, we were able to estimate the joint load back within OpenSim. Our results show that the peak tibiofemoral compression force reduced significantly compared to the unpowered condition with the assistance. It reduced by 10.2% when the assistance was active. Additionally, the vasty muscles, which are vas lat and vas med, showed reductions in the phase when the assistance was active as well. Vastus lateralis reduced by 19.4% and vastus medialis reduced by 18.7% with the assistance compared to no assistance. These results confirm our primary hypothesis. The exoskeleton assistance did reduce the muscle forces of the primary knee extensor muscles when the assistance was active, and also reduced the knee joint load during the assistance phase.